So, good afternoon, everyone. Without wasting any time, I would like to start my talk because slides are little around 50 slides. So, one should understand what do you mean by a poison. All things are poison. All things are poison, and nothing is without poison. Only and only the dose makes a thing not a poison. Even water and oxygen can be toxic if too much is taken, drunk, or absorbed. So, what do you mean by poison? Poison is a substance in the form of liquid, gas, or a solid form which produces ill health by causing a chemical reaction in the body and altering the cellular function. And toxicology is the branch dealing with the detection and treatment of poison. What is the classification? It is according to the site of action. It can be classified poisons having local action, having remote action, having local and remote both actions. According to the target organ affected, there may be all systems which can be affected because of poison. According to chemical nature, it is very important, alkaline poisons and acidic poisons like sulfuric acid, nitric and hydrochloric acid. According to the mode of poison, it can be deliberate, it can be accidental, or it can be environmental. And what are the factors which affect the poison? State of poison, very important. The gas form, which is most rapidly absorbed, the liquid form, and the solid form. Dose of poison is very important. Route of poison, the IV is the fastest route by which the poison can be absorbed, then inhalational, then intramuscular, and then the intact skin absorption is the slowest route. There are some factors which are related to the person who consumed the poison, like the gastric condition, the amount of the food, the type of the food, the genetic conditions, and the general conditions of the patient. So this is a brief about what is about the poisoning. Now coming to the management which we usually do, there is nothing new practice. I'll just touch upon the salient features, the new practice things about the poisoning. As you all know, when a patient or when a person is exposed to a poison by any route, what you have to do, you have to do the immediate ABCD of that patient in the form of airway, breathing, circulation, disability management. Then there comes the general and symptomatic measures which needs to be done. Then followed by either you prevent the absorption of poison or either you increase the elimination of the absorbed poison. Then followed by the administration of antidotes if at all it is available, and then the psychological counseling. There is another way to manage the poison. First you do the airway, breathing, circulation management, then followed by the rapid first look examination, monitoring and testing. Then you do or make a suspected diagnosis regarding about by taking the history, by doing the examination and investigations. And then followed by the management, which includes either the GIT management in the form of various methods which you all know, then followed by the enhanced elimination techniques, and then the antidotal technique. Now regarding the airway stabilization, what you need to understand is if the airway is unprotected, you immediately intubate the patient. Rapid sequence intubation with pre-oxygenation using the neuromuscular blocking agent is the best approach to secure the airway. Muscle relaxant of choice should be the rocuronium as far as organophosphorus poisoning is concerned and acute digoxin toxicity is concerned. Now, is the routine coma cocktail regime is still warranted? The American Society of Toxicology and the European Society of Toxicology say no. Why? It should be individualized as per the patient needs. Dextro should be empirically administered when there is a doubt whether the patient is hypoglycemic or not. Naloxone when there is a suspicion of narcotic overdose. And thiamine is limited to the patient suspected of chronic alcohol intake or when you have a symptoms of Wernicke's and encephalopathy. Regarding flumazenil, should not be used even when the benzodiazepine causing toxicity is suspected because it can precipitate benzodiazepine withdrawal and cause seizures as well. Now few words about the aspirin poisoning regarding the airway, breathing and circulation management. Salicylate or aspirin poisoning, it causes tachypnea and hyperpnea due to medullary stimulation because of the effect of poisoning, and it causes the trap of salicylate in the blood. So such type of hyperventilation is beneficial for the patient. One should not intubate the patient. Otherwise you will suppress the medullary response and you will harm the patient. Of course, if the patient is having the ARDS or a respiratory failure or neurologically his GCS is going down, then there is an indication for intubation, not for the hyperpnea and tachypnea. Few words about the paraquat poisoning regarding the airway management. It is a herbicidal poison. As you all know, the mechanism is lipid peroxidation. Lung is the most common organ which got affected. So minimal use of oxygen should be done to avoid the lung parenchymal damage. Now coming to the tox syndrome, what do you mean by tox syndrome? So tox syndrome is a clinical footprint characterized by a group or constellation of signs and symptoms due to the toxic effect of the chemicals in the body. It helps in focusing the diagnosis of the patient to the few chemicals which have similar symptoms and effects. It helps in the rapid detection of the suspected cause. These are the group of drugs which needs to be needs and toxindromic approach like cholinergic, anticholinergic, sympathomimetics, opioids and serotonin poisoning. Now coming to the poisoning management, you need to do the GIT decontamination, there are some enhanced elimination techniques, there are some antidotal therapy and there is supportive care. Now what GIT decontamination includes? It includes activated charcoal, gastric lavage, MSS, whole bowel irrigation, endoscopy or surgery. I am not going to discuss in detail about that. But what do you need to know is the decision to perform the GI decontamination, which is based upon the type of poison, the time from ingestion to presentation, and prediction of the severity, the dose in which the poison is taken. Gastric lavage, it is the first sample, stomach content, which should be preserved for chemical analysis. There are various techniques in which you can do the gastric lavage. One should know the contraindications before doing the gastric lavage. It is absolutely contraindicated in corrosive poisoning, except carbolic acid. Relatives are very list like convalescent poisoning, comatose patients, volatile poison, upper GIT disease. In drowsy patients or unconscious patients, one should intubate the patient before you attempt the gastric lavage. Benefit of gastric lavage is there once you receive the patient within 1 hour of your ingestion, and efficacy decreases with greater delay in ingestion and treatment. So gastric lavage, but routinely is not indicated currently. Agents which are highly toxic and not bound well by activated charcoal or causes delay in gastric emptying, then only it is indicated. There is no added benefit for late presenters. Regarding few words about the activated charcoal, it is the first line agent for the treatment of poisoning, especially for late presenters. It is superior to gastric lavage. Gastric lavage followed by or preceded and followed by activated charcoal must be more effective than activated charcoal alone at preventing drug absorption. Whole bowel irrigation, few words, it is used for drug packers. Now coming to a new thing, lipid emulsion therapy. Lipid has been used as a nutritional supplement for delivering calories or essential fatty acids to the patient. But nowadays, lipid emulsion therapy is used as a carrier vehicle in drug delivery. It is used as an antidote for lipophilic drugs overdose and for the attenuation of reperfusion injury. There are various mechanism of actions. It is available in 10%, 20% and 30%. The most commonly used is 20% preparations in a dose of 1.5 ml per kg over 1 minute, followed by 0.25 ml per kg per minute for 60 minutes. Total dose not to exceed by more than 10 ml per kg over 30 minutes. What are the indications? The most common indication is local anesthetic toxicity, and there are various reports of lipid emulsion therapy reversing the toxicity of calcium channel antagonists, TCA, benzodiazepines, anticonvulsants and beta blockers. Now coming to analytical toxicology, it is a very important topic. There is a very good book available or published by the WHO available on the web, like Basics of Analytical Toxicology. One should read if you are having an interest in this. It is the most important evidence of poisoning. Samples are taken from vomiters, gastric lavage, blood, urine and stool. There are two tiers of tests, tier 1 and tier 2. So tier 1 and tier 2 are quantitative tests in which the list of drugs are tested, the alcohols are tested and methemoglobin or carboxyhemoglobins are tested. These are the serum toxicological assay tests which everybody knows apart from the routine investigations. What do you need to know? The new thing is about the advanced toxicology test, the tier 2 test. If the patient is not improving despite your supportive treatment, despite your initial resuscitative measures, first you should contact to a senior toxicologist or an experienced toxicologist. And once, if he is also not able to make a diagnosis, then you will go for such kind of test, which include gas chromatography, mass spectrometry or liquid chromatography, mass spectrometry. The advantage is, it identifies drugs and metabolites and measures unknown substance and their metabolites at minuscule level. But the disadvantage is, it is very costly, machines are very costly. There is a long turnaround time and you need an expertise to identify and to do for processing such tests. There is a qualitative test in which you can test these list of drugs you can test in urine by using such reagents now which are available easily. Coming to forensic toxicology, we are living in an era of medico-legal importance, medical negligence. Everybody is after us to put us behind the bars. So one should be aware that medical management is very important. You should, first priority is to save the life of the patient, but simultaneously you should be well aware how to send the samples, how to collect the samples to prevent medical legal negligence or medical legal legalities for this management. So one should know the medical duties. The first duty is to save the life of the patient, then the legal duties and how to collect the sample. So the legal duties, one should know each and everything regarding the demographic profile of the patient. MLC should be made for every patient and police should be informed about it. Avoid giving opinion whether verbal or in written. Don't give any opinion either in verbal or in written on a mere suspicion, because if it is proved wrong, you will be behind the bars or the legal issues will be there. Collect, preserve and dispatch all the suspected material to the chemical examiner. Try to arrange for a dying declaration in the presence of magistrate, but if death is imminent, you are not able to collect or arrange for a magistrate, you yourself can take a dying declaration. Maintain a detailed record of every poisoned patient treated by you. Samples of suspected poisoning patients can be collected. These are the source where you can collect their samples. Dispatch of the sample is very important. It should be properly sealed and labeled. Properly labeled, nature of the preservative should be there. There should be, all the labels should be prepared in 3 copies. One to be pasted on the bottles, the other to be handed over to the chemical examiner, and 1 copy should be kept with you. Now coming to the latest techniques, what are the methods for enhanced elimination? There are 2 methods, the corporeal and extracorporeal. So these are the various enhanced techniques with which you can do the elimination of the toxins. What are the indications for enhanced elimination techniques? When there is a severe intoxication, when there is a progressive deterioration, despite doing everything and supportive therapy, patient is not improving. When there is an impairment of normal drug excretory mechanism in the presence of hepatic or renal insufficiency, or when there is an intoxication with agents with metabolites or delayed effects, an intoxication with a drug which is you need to be excreted faster. So what are those extracorporeal therapies? So there are a variety of extracorporeal therapies available. Coming to hemodialysis. Everybody knows about the principle and technique of hemodialysis, but one should know about, for dialysis to be effective, the toxin should be smaller in size, molecular weight should be less than 500 Daltons, it should be highly water soluble, low protein binding, and should have a smaller volume of distribution. There is a mnemonic called unstable for indications of hemodialysis. Now coming to hemofiltration. So hemofiltration, the rate of removal of toxin is influenced by the degree of protein binding, the ultrafiltration and the sieving coefficient. Hemofiltration is more effective than hemodialysis. It can efficiently remove high molecular weight toxins up to 40,000 Daltons, like methotrexate, vancomycin, methanol, thallium and lithium. Regarding hemoperfusion technique, in hemoperfusion, blood is pumped directly through a column containing an absorbent material, maybe it a charcoal or a resin. What are the indications? Indications for carbamazepine, barbiturates and theophylline. Advantage, because the drug or toxin is in direct contact with the absorbent material, drug size or water solubility and protein binding are not important factors. For most drugs, achieve greater clearance rate than hemodialysis. There are some disadvantages. Systemic anticoagulation is required, offer in a higher dose than hemodialysis, and thrombocytopenia is a common complication. So hemoperfusions can be done in these subsets of toxins. Regarding the CRRT, I have 1 minute left. So regarding the CRRT, the role of CRRT, everybody knows. CRRT is effective for slow continued in a hemodynamically unstable patient. So CRRT is effective for the slow continuous removal of toxins with high tissue binding, with large volume of distribution, and with drugs having low or slow rebound phenomena. Regarding the plasmapheresis, it involves extracorporeal separation of plasma from cellular components. You can replace it either by FFP or by albumin. The advantage, removes very large and high protein bound drugs. Management of toxicity is complicated by massive hemolysis. Regarding the CSF exchange, methotrexate toxicity after inadvertent administration causes neurological damage. CSF is drained via ventricular catheter and the sterile solution containing the albumin and sodium chloride is inserted into the lumbar subarachnoid space. Now regarding the ECMO. So what the ECMO do? ECMO maintains the cardiac output in severely intoxicated patients with hemodynamic instability, patients with cardiac dysfunction, with respiratory function dysfunction. Despite doing everything, patient is not improving, you can offer the ECMO. It helps in improving the organ perfusion, allows natural elimination of the drug and toxin substances. RRT may be used during ECMO for dialysable toxin. This is the advantage. So ECMO in poisoning, if mortality risk of the patient is 50%, ECMO is recommended, but if it is more than 80%, then it should not be delayed. Everybody knows the type of ECMO, it is VA ECMO and VV ECMO. So what is the role of ECMO in poisoning? It acts as a bridge to recovery. It acts as a bridge to antidote, bridge to transplant, and bridge to toxin elimination. So this is how the ECMO finds its role and place in poisoning. So my conclusion. So first and foremost is airway breathing circulation. Initial supportive care is very important for the initial management. Extracorporeal therapies are now available which can be used very wisely. An antidote is the cornerstone of the therapy. If it is available after supportive measures, you can use the antidotes. If it is not available, then you go for supportive therapies. And in the end, treat the patient, not the poison. Thank you.
Thank you.